podcast is for educational and informational purposes only. It is not medical advice, legal advice, or professional advice of any kind. And it does not create an attorney-client, physician-patient, or other professional relationship. Any discussion of cases, outcomes, standards of care, statutes, or regulations is general in nature, may be incomplete, and may vary by jurisdiction and over time. Listeners should consult their own attorney, malpractice carrier, risk manager, or qualified clinician for advice on any specific matter. Any case discussions are based on public records, de-identified information, or educational reconstruction. The views expressed are those of the speakers and do not necessarily reflect the views of any employer, hospital, health system, insurer, or affiliated organization. Welcome to On the Record, the long-form case deep dive series of the Chartered Defense. I'm Brian.
I'm Sarah.
And I'm Michael Coleman. We're going to spend the next hour and a half walking through a single case from 2016. The clinical timeline, the litigation that followed it, the expert testimony, the discovery fights, and the way the case ended without ever reaching a jury. Most of all, what a practicing physician can take from it onto the next shift.
The case involved a hospital in the Northeast, a Joint Commission certified primary stroke center, and was filed in state court in 2018. The clinical event happened on an evening in 2016. The case settled 4.5 years later, on the eve of jury selection. Between those two dates, 11 defense experts were retained. 3 plaintiff radiology experts opined that an early imaging finding was missed. The hospital's own electronic stroke orders set was produced as an exhibit, and a hospital-wide picture archiving system audit trail became one of the case's most distinctive evidentiary feature.
The patient is a husband and father, 50 years old at the time of the event, healthy by every standard the chart documents. No chronic conditions, no medications, no allergies, non-smoker. He was a previously healthy adult.
On the evening in question, he was last seen normal at approximately 6:30 p.m. by his daughter. The neurology consult note that evening would record her observation in plain words. He was, quote, getting ready to cut the grass. That's the time the stroke clock starts. 6:30 p.m.
That detail matters more than it might sound like. Last known well is the fixed reference point for every reperfusion decision that follows. Every minute counts from that minute. Every threshold, 3 hours for standard alteplase, 4.5 hours for the extended window, 6 hours for groin puncture for thrombectomy under the 2015 guidelines, is measured from that point.
Shortly after 7 p.m., he was found unconscious on the lawn of his residence. Emergency medical services was dispatched at 7:20 p.m. and arrived on scene at 7:24 p.m. The ambulance crew documented a Glasgow coma scale of 8 during transport. He arrived at the emergency department at 7:47 p.m. About 1 hour and 17 minutes after he was last known well.
The timing matters legally as well as clinically. He arrived inside the 4.5-hour window for intravenous alteplase. He arrived inside the 6-hour window for endovascular thrombectomy. The bulk of the treatment opportunity, by the published 2015 American Heart Association and American Stroke Association guidelines that were operative at the time, was theoretically intact when he came through the doors.
And the hospital that received him was a Joint Commission certified primary stroke center. The state had also designated it as a primary stroke center. By 2016, that was a credentialed, audited, publicly held out level of stroke capability. It carried with it a set of expectations about how the next minutes would unfold.
Triage. The emergency department record documents 2 nursing assessments. A quick triage exam by one registered nurse at 7:48 p.m. within 60 seconds of arrival. A second triage examination by a different registered nurse at 7:50 p.m. The Glasgow Coma Scale at the second triage was 9.
GCS 9. That is functionally unresponsive. Eyes opening to pain, incomprehensible sounds, motor withdrawal. A patient like this in the emergency department at the front door is, by every published clinical definition, a stroke alert until proven otherwise.
At 7:56 p.m., door plus 9 minutes. The emergency department physician examined the patient. The chart documents the diagnosis as, quote, CVA, altered mental status. That was within the door to physician target, 10 minutes. Listed on the hospital's own internal stroke protocol.
That is the only target the hospital met that night. The protocol document itself becomes one of the central exhibits in the litigation, so it's worth slowing down on what it said.
The hospital's emergency department had a printed and electronically embedded order set for stroke alerts. The goals listed verbatim on that order set were: door to emergency department physician examination, 10 minutes. Door to neurologist, 15 minutes. Door to CT scan, 25 minutes. Door to CT and lab results, 45 minutes. Door to drug, meaning intravenous alteplase, 60 minutes.
Those numbers are not the hospital's invention. They are the door-to-needle targets the American Heart Association has been promoting through its Target Stroke initiative since well before 2016. They map onto the 2013 American Heart Association and American Stroke Association Acute Ischemic Stroke Guideline, which set door-to-needle within 60 minutes as a Class 1 level of evidence, a recommendation. The hospital had aligned its internal protocol to the published national framework.
At 7:56 p.m., when the emergency department physician diagnosed cerebrovascular accident, the patient had been in the building for 9 minutes. Door to neurologist target, 15 minutes. 6 minutes remaining. Door to CT target, 25 minutes, 16 minutes remaining. Door to needle target, 60 minutes, 51 minutes remaining.
But for any of those downstream targets to be met, one thing had to happen first. The stroke alert had to be activated. The stroke alert is the mechanism. It is not a checkbox. It is the call that pulls the on-call neurologist out of whatever else they are doing, alerts the radiology technologist to expect a stat non-contrast head CT, primes pharmacy to prepare alteplase, and pulls the stroke nurse to the bedside.
The stroke alert was not activated.
That sentence is the upstream pivot of the entire case. Everything that happens for the next 3 hours flows from it. The defense expert vascular neurologist will later state in his expert disclosure that the absence of a stroke alert initiated by the emergency department physician is the source of the delay in this case. The plaintiff's vascular neurologist will agree that the stroke alert was not called. They disagree about who is responsible for it. They do not disagree about whether it happened.
The emergency department physician ordered at 7:56 p.m. a non-contrast computed tomography scan of the brain and cervical spine, a chest X-ray, and laboratory studies including toxicology, cardiac enzymes, urine studies, and basic chemistries. The chart documents the symptoms driving the workup as, quote, altered mental status, and the patient unresponsive, found on the ground.
One thing the order did not include was a CT angiogram. The 2015 American Heart Association focused update on endovascular treatment said this clearly. If endovascular therapy is being considered, a non-invasive intracranial vascular study is strongly recommended during the initial imaging evaluation. But, and this is important, vascular imaging should not delay alteplase when alteplase is indicated. The framework was parallel, imaging and treatment moving together, not one waiting for the other.
The clinical question I'd ask in real time, looking at a 50-year-old found unconscious with forced gaze deviation and no movement on one side, is this a large vessel occlusion? And the answer to that question in 2016 in a Joint Commission certified primary stroke center should likely have been yes. The downstream of yes is you order CT and CT angiogram together, you call neurology, you alert pharmacy, and you start thinking about transfer logistics all in parallel. That is the pathway the stroke alert is supposed to start.
The chest X-ray was interpreted at 8:23 p.m. and electronically signed at 8:27 p.m. by the radiology attending. The result was, quote, unremarkable, clear. The CT brain and cervical spine performed shortly after. The hospital timeline documents the scan at 8:27 p.m. The expert disclosures cite a slightly earlier time, approximately 8:18 p.m. The radiology resident dictated the report at 8:54 p.m. The radiology attending electronically signed it at 8:59 p.m., which is 1 hour and 12 minutes after the patient came through the door.
The CT impression was reported as, quote, brain parenchyma, unremarkable, no hemorrhage or CT evidence of infarction. Impression, no evidence of acute intracranial abnormality. The signed report did not document a critical findings call back to the emergency department.
Door to CT signed 72 minutes. The hospital's own protocol target for door to CT and lab results was 45. They were already nearly 30 minutes outside the protocol target by the time the radiology read was signed. And the stroke alert that would have triggered the parallel pharmacy and neurology workflow had still not been called.
At 9:24 p.m., the emergency department physician re-examined the patient. At 9:26 p.m., 2 minutes later, he ordered a magnetic resonance imaging study of the brain. At approximately 9:30 p.m., per the plaintiff's allegation, he placed the first telephone call to the on-call neurologist. Defense expert disclosures placed that call slightly later, between 9:39 and 9:46 p.m. The plaintiff's defense disclosed neuroradiology expert calculated the resulting delay to neurologist contact at, quote, at least 1 hour and 43 minutes.
Door to neurologist target, 15 minutes. Actual, somewhere between an hour and 43 minutes and an hour and 46 minutes. By the disclosed defense expert's own number, that is 12 times the protocol target.
The gap between the CT being signed at 8:59 p.m. and the call to neurology happening around 9:30 is worth a moment. 31 minutes of clinical time during which the chart does not document why neurology was not yet on the phone. The reason that gap exists is most likely that the stroke alert was not activated. Without the stroke alert, the entire cognitive and operational load of a high acuity, time-sensitive patient sat on one emergency department physician who was simultaneously responsible for every other patient in the department that night. A stroke alert protocol exists precisely to redistribute that load. With the protocol activated, neurology is already engaged in parallel with imaging review, pharmacy is already primed, and the stroke nurse is already at the bedside. Without the protocol activated, the emergency department physician is solo managing a possible large vessel occlusion.
The MRI was performed between 9:36 and 10:01 p.m. At 10 p.m., the MRI results were discussed with the emergency department physician. The MRI showed a large area of diffusion restriction involving the left frontotemporal region and the left basal ganglia, consistent with a hyperacute to acute left middle cerebral artery territory infarct. The MRI also showed loss of the left middle cerebral artery flow void. Translation: the MRI confirmed an acute large vessel occlusion stroke in the left middle cerebral artery territory. Severe enough deficit, large enough territory, classic acute embolic appearing pattern. At 10:09 p.m., per his deposition testimony, The on-call neurologist received a phone call from the emergency department physician informing him the MRI had been completed and showed an ischemic stroke. At 10:16 p.m., a second call was placed to the neurologist. During that second call, the last known well of 6:30 p.m. was confirmed.
3 hours and 46 minutes from last known well to confirmation of the stroke clock.
The on-call neurologist arrived in the emergency department somewhere after 10:20 p.m. Different plaintiff filings cite different arrival times. Some say 10:20 p.m., some say 10:45 p.m. The chart records a National Institutes of Health stroke scale assessment and a quality measures stroke assessment in the chart at 10:20 p.m. The neurology consult note documents an NIH stroke scale that, by defense expert calculation, was independently scored at 24 and 26 by two different providers.
An NIH stroke scale of 24 to 26 is a severe stroke. To put it in plain clinical terms, the patient is mute or has global aphasia, has dense hemiparesis, has gaze deviation, has visual field deficit, and is not responding to commands by any standard. This is a malignant trajectory presentation, if not reperfused.
At 10:50 p.m., the on-call neurologist authorized the administration of Alteplase, brand name Activase, for the patient. At approximately 10:57 p.m., the loading dose was administered. Time from last known well to Alteplase loading dose, 4 hours and 27 minutes. The standard 2013 guideline windows for Alteplase, 0 to 3 hours as Class 1 Level A, 3 to 4.5 hours as Class 1 Level B, with additional exclusions, including a National Institutes of Health stroke scale greater than 25. The patient received Alteplase 3 minutes inside the 4.5-hour outer window.
That margin is worth pausing on. 3 minutes. With an NIH stroke scale documented independently at 24 and 26, depending on the provider, a value that straddles the greater than 25 exclusion threshold for the extended window. The treatment was given, but the timing was at the literal edge of what the operative 2013 guidelines supported.
The patient was not transferred to a thrombectomy-capable comprehensive stroke center. The hospital was not thrombectomy-capable in 2016. Both the plaintiffs and the defense's expert disclosures agree that the hospital did not have an established, instituted drip and ship protocol, a written, pre-arranged transfer pathway for large vessel occlusion patients to be moved to a comprehensive stroke center after Alteplase initiation. The defense's own cross-disclosure of the hospital's stroke director, who was also the on-call neurologist that night, acknowledges that a drip and ship protocol, or algorithm, had not been instituted at the hospital prior to the date of the event.
That detail does some work in the litigation that we'll come back to in Part 3. For now, it's enough to note the operational fact. There was no pre-existing transfer pathway for the patient to enter.
The patient was admitted to the hospital. Length of stay, 9 days. On hospital day 5, a follow-up MRI confirmed the prior findings without new acute infarcts. On hospital day 8, a cardiology consultation was performed by the cardiology team. The consult note recorded a transthoracic echocardiogram that was, quote, suggestive of a PFO with right-to-left shunting, but not clear. The consultant noted, quote, a TEE will be performed to better define anatomy. Anticoagulation will be required once cleared by the neurology service. No absolute indications for PFO closure at this time.
PFO patent, foramen ovale. About 1 in 4 adults has a small interatrial communication that closes incompletely after birth. The clinical question in a young, otherwise healthy stroke patient, particularly with a cortical embolic appearing infarct, is whether the PFO is the mechanism of paradoxical embolism. cryptogenic stroke in a healthy 50-year-old with a PFO, and no other vascular risk factors fits that profile.
On hospital day 9, the patient was discharged from the hospital. The discharge summary documented the discharge diagnosis as cerebrovascular accident. The discharge instructions, per the defendant's answers to requests for admission, were for, quote, ischemic stroke treated without warfarin. On the same day, the patient was transferred to a regional acute rehabilitation hospital.
The discharge instruction is worth a comment because in 2016, the secondary prevention question for a cryptogenic stroke patient with a PFO was its own area of evolving evidence. The Patent Foramen Oval in Cryptogenic Stroke study published in 2002 had not shown statistical superiority of warfarin over aspirin in this specific population. The 2014 American Heart Association Secondary Stroke Prevention Guidance and the 2016 American Academy of Neurology Practice Advisory both supported antiplatelet therapy in patients with a PFO and a cryptogenic stroke when there was no other indication for anticoagulation. The major randomized trials that would later support percutaneous PFO closure in selected patients, key lows reduce, and the long-term follow-up of Respexon were not published until September 2017, 17 months after this discharge.
That timing matters because in any retrospective discussion of the secondary prevention regimen, we have to anchor to what the published literature supported on the date of discharge, not what the field came to agree on a year and a half later.
Right. The teaching point is the timing of the evidence. The discharge regimen was guideline consistent for what was knowable at the time.
The patient's permanent injuries, as alleged in the operative complaints, included right hemiparesis, severe cognitive impairment, brain damage, aphasia, auditory comprehensive impairment, apraxia, impaired posture and difficulty walking, and decreased balance, coordination, motor control, and strength.
That is the human cost. A previously healthy 50-year-old husband and father last seen by his daughter at 6:30 p.m. getting ready to cut the grass. He survived. He could not return to the way he was before.
2 years after the stroke, the patient and his family filed suit in state court. The complaint was filed in 2018 in state court. The plaintiffs were the patient, his wife, and children, alleging marital and parental loss of consortium.
The defendants named were the emergency department physician, the radiology resident, and the radiology attending, the limited liability company that contracted to provide radiology services, the on-call neurologist, who was also the hospital's stroke director, the professional corporation through which his neurology services were provided, and the hospital itself.
6 clinical defendants and 2 corporate defendants. That is a typical scope for a complex hospital-based stroke malpractice case.
The complaint alleged professional negligence and medical malpractice, centered on what it described as a failure to properly assess and evaluate the patient for a neurological condition, failure to timely diagnose ischemic stroke, and failure to timely administer alteplase. The specific allegations against the radiology defendants included failure to identify what the complaint described as a hyperdense left middle cerebral artery on the non-contrast CT, which the complaint alleged was, quote, most compatible with an early MCA distribution infarct.
Filed alongside the complaint was a certificate of reasonable inquiry under the state's good faith certificate statute for medical malpractice plaintiffs.
For a non-lawyer audience, in this jurisdiction, a plaintiff filing a medical malpractice case has to do 2 things at the threshold. First, perform a reasonable inquiry. Second, attach a written opinion from what the statute calls a similar healthcare provider, stating that there appears to be evidence of medical negligence. The state Supreme Court has clarified that the similar healthcare provider has to meet specific criteria, generally same specialty, same board certification, if applicable, active practice within the relevant window. The opinion letter is a filing gatekeeper. It is not the trial expert disclosure. It is, in effect, the document that opens the courthouse door.
Discovery, in this case, lasted just under 4 years. The docket is dense, hundreds of filings. We're not going to walk every motion. We're going to walk 3 pressure points that define the discovery phase.
The first pressure point was the early settlement. The parties participated in mediation in early 2020. Following the mediation, the plaintiffs reached a confidential settlement with the hospital, the emergency department physician, and the radiology resident. The combined settlement amount was under $500,000. Withdrawals of action were filed against those 3 defendants.
The settlement figure here is worth mentioning. A settlement is not a verdict. It is not a finding that the defendants met the standard of care, and it is not a finding that they violated it. It is a negotiated risk transaction. In a stroke delay case, the damages may be enormous, but the litigation risk is usually concentrated around causation. The plaintiff has to prove more than delay. They have to prove that earlier recognition, earlier alteplase, earlier transfer, and earlier thrombectomy evaluation probably would have changed the outcome. And each step in that chain can be attacked. That is why a relatively low settlement can make sense even in a catastrophic injury case. It may reflect insurance limits. It may reflect uncertainty about causation. It may reflect apportionment risk among multiple defendants. Or it may reflect a decision by one side to secure a guaranteed recovery and the other side to buy peace without admitting fault. Some defendants settled their portion of a high damages but high uncertainty case at a discounted risk value. In malpractice litigation, settlement value is not just about how bad the outcome was, it is about how confidently a plaintiff can connect a particular defendant's conduct to that outcome.
And under the state's apportionment statute, settled defendants do not exit the case in the way a non-party does. They remain on the verdict form. The remaining defendant's exposure at trial is reduced by the settled defendant's percentage of negligence, not by a dollar credit against the settlement. That comes from a 2001 state Supreme Court decision we'll come back to in Part 5.
Days before the partial settlement, the plaintiffs had filed an offer of compromise of $6 million against the radiology attending and the Radiology Limited Liability Company.
The state's offer of compromise statute works like this. In a healthcare negligence case, the plaintiff may file an offer of compromise no earlier than 365 days after service of process. If the defendant does not accept within 60 days, the offer is deemed rejected. After trial, if the plaintiff recovers an amount equal to or greater than the offer, the court adds 8% annual statutory interest to the recovery. The state Supreme Court has described that interest as punitive in character, tied to the rejection of an advantageous settlement offer rather than to compensation for the underlying injury. Importantly, settlements do not trigger the interest. Only a trial verdict at or above the offer does.
The radiology defendants now had 2 simultaneous pressure points, a $6 million litigation risk benchmark with a conditional 8% annual interest exposure if they went to trial and lost above the offer, and the apportionment architecture sitting in the background, meaning that even after the hospital and the emergency department physician settled, the remaining defendants were still on the verdict form along with the settled parties.
The second pressure point in discovery was the Picture Archiving System Audit Trail, the PACS Audit Trail.
For the audience, a PACS audit trail is the metadata generated by the imaging system. It records who logged in, what study they accessed, what action they took, view, dictate, sign, and from what network address. The Health Insurance Portability and Accountability Act security rule requires covered entities to maintain audit controls of this kind on systems that contain electronic protected health information. The audit trail is generated automatically. It is not, in most jurisdictions, automatically produced as part of the patient's medical record. But it is electronic information about the medical record, and in litigation, it is generally discoverable when relevant to a disputed issue.
We have talked about forensic audit data in earlier episodes: cell tower records, badge swipe logs, EMR audit trails. The pattern keeps coming back. Digital evidence that the witness did not anticipate. A clinician who tells a story in deposition that does not match the metadata. The lesson is the same one that keeps repeating across our cases. When digital evidence outlasts memory, the discipline shifts to what you can verify, not what you can recall.
The plaintiffs requested production of the patient's electronic medical record and the PAC's audit trail. The Radiology Limited Liability Company initially objected. After the plaintiffs filed a motion for order of compliance, the radiology defendant produced over 300 pages of audit trail records.
The Information Technology Director of the Radiology Limited Liability Company was deposed on multiple dates. The plaintiffs disclosed an information technology expert to testify on how the radiology PACS system assigns network identifiers and what the relevant identifiers in the audit trail meant.
The third pressure point in discovery was peer review privilege. The plaintiffs requested production of the hospital's Joint Commission Primary Stroke Center certification materials. The American Heart Association Get With The Guidelines program data, and the hospital's internal stroke team logs.
The hospital objected, asserting privilege under the state's medical peer review privilege statute. The leading state Supreme Court authority on this statute establishes that the privilege is real but narrow. It protects the proceedings of a medical review committee actually engaged in peer review. It does not automatically protect every quality improvement document, every certification file, every operational log, just because the hospital labels it quality-related or sends it to a committee.
The category that gets contested in this case is the certification materials and the operational stroke logs. The plaintiff's position is that the order set, the call logs, the timestamps, the protocol documents in clinical use. Those are ordinary course operational records, not committee deliberations. The hospital's position is that the certification documents and quality data fall under the peer review privilege. The court did not rule on that dispute.
The hospital settled before the privilege fight reached a judicial decision, so this case does not produce a holding on the scope of the state's peer review privilege. The privilege claim remained untested.
But one document did make it out into the discovery record. The hospital's emergency department stroke alert order set, the one we've been quoting from, was produced as Exhibit E to a discovery motion. The contents of that order set, including the door-to-needle goal of 60 minutes, became part of the open record.
That document, sitting in the EHR listing those targets, is the central exhibit of the entire case. The hospital was a Joint Commission certified primary stroke center. The order set existed. The targets aligned with the national framework. That is what the protocol said. The case is what happened to that protocol on the night in question.
The plaintiffs disclosed expert witnesses across radiology, neurology, physiatry, life care planning, and economics. We're going to focus on the four whose testimony defined the trial theory. 3 radiologists and 1 vascular neurologist.
The plaintiff's lead radiology expert was a board-certified diagnostic radiologist and neuroradiologist from out of state. The plaintiff's second radiology expert was also board-certified in diagnostic radiology. The third, a board-certified neuroradiologist with subspecialty training in interventional neuroradiology, was disclosed both for radiology breach and for treatment candidacy. We'll come back to her because her role in this case becomes complicated.
The plaintiff's radiology theory had 2 parts. First, that the hyperdense left middle cerebral artery sign was visible on the early non-contrast CT and was missed. Second, that the missed finding deprived the patient of timely identification of the large vessel occlusion.
A normal middle cerebral artery on a non-contrast CT can be visible as a soft tissue density vessel coursing through the sylvian fissure. When the artery is acutely occluded by a fresh thrombus, the clot itself can be hyperdense relative to flowing blood. The sign appears as a relatively bright, dense vessel. It is a marker of intraluminal thrombus.
The lead plaintiff radiology expert filed an initial expert disclosure stating that the early CT, quote, demonstrated the existence of an ischemic stroke, and that the findings were not subtle and were easy to visualize. That language was amended in a later disclosure. The amended disclosure narrowed the testimony, stating that the CT, quote, demonstrated the presence of a clot in the left middle cerebral artery, which was not subtle and was easy to visualize. The amended disclosure further opined that the radiology attending, quote, deviated from the standard of care when she failed to identify the presence of a clot in the left middle cerebral artery in her interpretation of the CT scan.
The literature on the hyperdense artery sign is worth discussing because it's central to the defense rebuttal in Part 4. The most cited contemporary meta-analysis is Mayer and colleagues, published in the journal Stroke in 2015. That meta-analysis pooled data from 16 prior studies plus the IST3 cohort, a total of 1,175 patients with angiographic correlation. The pooled sensitivity for the hyperdense artery sign was about 52%. The pooled specificity was about 95%.
In the population of patients with confirmed angiographic occlusion, only about half show a callable hyperdense sign on non-contrast CT. But when the sign is present, it is a strong marker of true occlusion. In the author's own framing, the absence of the sign does not predict normal arterial patency.
So, as a matter of the radiology literature, the sign is moderately sensitive and highly specific. A read that does not call the sign is not by itself a deviation from the standard of care, because half of true occlusions don't show a callable sign. But the plaintiff radiology experts opined that this CT had a clearly visible sign that was missed.
The plaintiff's vascular neurology expert was a board-certified vascular neurologist from a regional stroke center out of state. She authored the Similar Provider Opinion of Similar Healthcare Provider, directed at the on-call neurologist, who was also the hospital's stroke director.
Her disclosure outlined breach in two distinct categories. First, a clinical care category, failed to timely diagnose the hyperdense MCA, failed to timely order the administration of alteplase, failed to offer and recommend mechanical thrombectomy in addition to alteplase, failed to order the patient be prepared for transport for thrombectomy. Second, and this is the part that distinguishes her testimony from a standard treating physician malpractice case, a systems and administrative category, failed to add mechanical thrombectomy in the hospital's stroke algorithm, and failed to establish a drip and ship protocol.
That is a stroke director theory. The plaintiff's vascular neurologist is not just saying the on-call neurologist was slow on the night of the event. She's saying he failed in his contractual and institutional role as medical director of the stroke program. That he was responsible for instituting the protocols he was then operating without on the night of the event. Whether that theory holds up depends on the language of his contract and what hospital leadership had assigned to the stroke director role. Defense expert testimony in Part 4 pushes back on this directly.
The plaintiff's third radiology expert, the board-certified neuroradiologist with subspecialty training in interventional neuroradiology, was disclosed for both radiology breach and treatment candidacy. Her testimony included opinions that the early CT showed a hyperdense left MCA sign consistent with a clot, that the patient was a candidate for both alteplase and mechanical thrombectomy, and that with timely treatment, the patient would have had functional independence in 90 days.
That last sentence is the core of the plaintiff's causation theory. We need to slow down on it because it intersects with the medical literature in a specific way.
The thrombectomy outcome literature for severe NIHSS strokes is the Hermes individual patient meta-analysis, published in The Lancet in 2016. Hermes pooled data from the 5 2015 randomized controlled trials of mechanical thrombectomy: Mr. Clean, Escape, Swift Prime, Extend IA, and Revascat. The total cohort was approximately 1,287 patients. for the National Institutes of Health stroke scale subgroup of greater than or equal to 21, the severe stroke subgroup, which is where this patient sits, Hermes reports an adjusted common odds ratio of 2.52 for a better 90-day modified Rankin scale outcome with thrombectomy compared to medical therapy alone. The 95% confidence interval is 1.4 to 4.54. The interaction p-value across NIH stroke scale strata was 0.45, meaning Hermes did not find evidence that severity meaningfully modified the treatment effect. That common odds ratio describes a shift across the modified Rankin scale, a movement toward better outcomes overall. It is not the same as the absolute rate of functional independence, defined as a modified Rankin scale of 0 to 2 at 90 days. The Hermes appendix data, as reported in secondary sources, places the absolute rate of functional independence in the NIH stroke scale greater than 21 subgroup at approximately 23% with thrombectomy, compared to about 14% with medical management. The exact percentages are appendix-derived and not printed in the main article text.
That is the medical evidence base for the plaintiff expert's claim of functional independence with timely thrombectomy. The state's lost chance doctrine in medical malpractice comes from a 2003 appellate court decision. The state recognizes the doctrine in a narrow form. The state requires the plaintiff to prove the patient probably would have had the better outcome with proper treatment, a categorical greater than 50% threshold. The state does not generally allow recovery for the loss of a sub 50% statistical chance in the way some other jurisdictions do.
Now look at the math against the categorical claim. The Hermes appendix data, when applied to a severe NIHSS patient like this one, indicates approximately a 23% absolute probability of functional independence at 90 days with optimal thrombectomy. That is a meaningful chance. It is roughly a doubling over medical therapy alone, but it is not a 50% or greater probability. So the plaintiff experts claim that the patient would have had functional independence, the categorical assertion implying greater than 50% probability, is more definitive than the underlying meta-analysis data supports. That is a credibility issue, not a structural inevitability of the legal system. An expert's job is to accurately represent the literature. The plaintiff's lawyers carry the burden of meeting the causation threshold. That is their job. The expert's job is honest testimony. If the literature does not support a categorical claim of independence, an expert should not make one. They should describe the chance of independence as the literature describes it, identify any patient-specific factors that move the probability up or down for this specific patient, and let the trier of fact evaluate causation. We will come back to this expert's statements in our closing and open about how the testimony might have affected the ending of the case. Remember what she said, and remember how it might not be supported by the medical literature available at the time or even currently.
The plaintiff's damages experts included a board-certified physiatrist with subspecialty board certification in brain injury medicine, a certified life care planner, and an economist.
The specific permanent partial impairment ratings, the dollar total of the life care plan, and the present value calculations from the economic loss report are not in the case file extracts available for this episode. The experts were disclosed and the reports were produced in discovery. The contents of those specific reports are not part of the verified record we can quote from.
That is an honest acknowledgement we want to make. We can describe the architecture of the damages case, physiatrist opining on permanency, life care planner building the future cost model, economist calculating present-day value, without quoting numbers that are not in the verified record.
Putting the plaintiff's case together. The radiology experts opined the hyperdense MCA sign was visible on the early CT and was missed. The vascular neurologist opined the on-call neurologist failed in both individual care and institutional duty as stroke director. The interventional neuroradiologist opined the patient was a candidate for thrombectomy and would have had functional independence with timely treatment. The damages experts built the future cost framework.
The plaintiff theory in a single sentence: protocol on paper, the stroke alert order set, the certification, the stroke director on call. System offline, no code stroke activation, no CT angiogram, no transfer pathway. Window lost, alteplase given inside the 4.5-hour window, but at 3 minutes inside. Transfer for thrombectomy never initiated.
The defense strategy after the partial settlement was sophisticated and multi-layered. The remaining defendants, the radiology attending, the radiology limited liability company, the on-call neurologist and his professional corporation, retained 11 expert witnesses. The architecture of the defense had 3 distinct layers.
Layer 1, Defense Neurology, retained to defend the on-call neurologist's individual care decisions. Layer 2, Defense Radiology and Neuroscience, retained to dispute the imaging breach and the causation chain. Layer 3, Empty chair experts, retained specifically to point fault back at the settled defendants on the verdict form.
That third layer, Imhao, the empty chair experts, is an interesting concept worth spending time on because it is the part most directly driven by the state's apportionment statute.
The defense neurology team retained 3 experts: a board-certified neurologist with subspecialty training in neurocritical care, a board-certified neurosurgeon, a board-certified vascular neurologist with academic credentials.
The neurocritical care neurologist's disclosure stated, verbatim, that any alleged delay in treatment by the on-call neurologist was attributable to the failure of the hospital's personnel to timely initiate a stroke alert and to contact the on-call neurologist sooner. His causation opinion was that by the time the on-call neurologist was notified, more than 3 hours after last known well, the patient was unlikely to receive thrombectomy within 6 hours of last known well and thus would not have been eligible for endovascular therapy in the operative 2016 framework. The neurosurgeon's disclosure stated that in 2016, there was no evidence to support a benefit of performing thrombectomy after 6 hours of last known well, and the standard of care was only to undertake the procedures in patients for whom thrombectomy could be performed within the 6-hour window. He further opined that the logistics in 2016 for arrangement and execution of transfer rendered it impossible for the patient to have received thrombectomy within 6 hours of last known well. The vascular neurologist's disclosure echoed the same architecture. He attributed the delay to the hospital's failure to timely contact the on-call neurologist and opined that, due to the extent of infarction at the time of evaluation, the patient was unlikely to benefit from alteplase or thrombectomy.
That is the defense neurology architecture in one frame. Even if everything the plaintiff's vascular neurologist says is true about how stroke director protocols should work, the on-call neurologist is not the cause of the delay. The hospital's failure to call the stroke alert is. Even if the on-call neurologist had been called immediately, by the time he was actually contacted, the 6-hour window for evidence-supported thrombectomy was already out of reach.
That last point, about the 6-hour window, is worth pausing on for the audience. The defense's framing is that in 2016, mechanical thrombectomy was Class 1, Level A, under the 2015 American Heart Association focused update only when groin puncture could be initiated within 6 hours of symptom onset. The major late window thrombectomy trials, DAWN and DEFUSE 3, that extended that window to 16 and 24 hours in selected patients with imaging mismatch were not published until early 2018. So a 2016 patient who could not reach a thrombectomy-capable center within 6 hours was, under the operative guideline framework, in territory that the 2015 guideline characterized as Class 2, B, Level C, uncertain effectiveness, additional randomized data needed.
That is an accurate framing of the 2016 evidence base. That doesn't mean thrombectomy beyond 6 hours was contraindicated. It was that thrombectomy beyond 6 hours was not yet established as routine guideline-supported standard care. Some advanced centers were performing thrombectomy in selected late presenting patients. But it was not the national standard. The important point to take away from this is that the defense medical experts are providing an opinion that shifts much of the blame towards the parties that have already settled, as the settled parties would have been the defendants in a position to activate the stroke alert.
The defense radiology lead expert was a board-certified diagnostic radiologist and neuroradiologist. He was originally retained by the on-call neurologist's defense team and then cross-disclosed by the radiology defendants, meaning both defense groups would call him at trial.
His disclosure stated that the early non-contrast CT, quote, did not reveal a callable hyperdensity in the left MCA distribution that would lead any of the providers, including the on-call neurologist, to conclude there was an obvious dense MCA or ischemic stroke on that imaging.
That is a defense-side rebuttal of the plaintiff radiology theory in the most direct possible terms. His position is that on this specific non-contrast CT in this specific patient, the finding was not callable. That is a case-specific image interpretation argument, not a challenge to the general validity of the sign.
Notably, his primary disclosure does not specifically address parenchymal infarction visible on the early CT. He addresses the absence of a callable hyperdensity. He addresses the MRI findings later that evening. He does not opine on whether the non-contrast CT showed parenchymal hypodensity or early ischemic change. That distinction matters, and we'll come back to it in a moment.
The radiology defense had one other notable feature. A second board-certified radiologist was retained by the radiology defendants to defend the radiology attending's read directly. That second radiology expert, a separate board-certified radiologist, withdrew as an expert on the eve of his deposition. The case file documents do not state the reason for the withdrawal. The defense's most strategically interesting move came near the end of the discovery period. The defense team for the on-call neurologist filed a cross-disclosure of the plaintiff's lead radiology expert.
For the audience, a cross-disclosure under the state's expert discovery rules allows a party to designate an opposing party's already disclosed expert as their own, meaning either side can call the witness at trial, and the cross-disclosing party can use the expert's prior opinions for their own purposes.
The defense cross-disclosure of the plaintiff's radiology expert did something specific. It cited his demonstrative diagrams in the colorized maps and overlays he had produced to illustrate his testimony, and stated, quote, Dr. A is expected to testify that the initial area of early infarction and edema he highlights on the CT of the head consumes more than 1/3 of the entire middle cerebral artery territory. The cross-disclosure further noted that the plaintiff's interventional neuroradiologist confirmed that finding on the demonstrative diagrams.
Translation: the defense took the plaintiff's own radiology expert's demonstrative exhibits and used them to argue that on the early, non-contrast CT, the parenchymal infarction was already extensive enough to consume more than 1/3 of the middle cerebral artery territory.
Why does that matter? Under the 2015 American Heart Association focused update, one of the 7 Class 1 criteria for mechanical thrombectomy is an Alberta Stroke Program early CT score. The aspects score of 6 or greater on the non-contrast CT aspects subtracts points for each anatomical region of the middle cerebral artery territory, showing early ischemic change. If parenchymal change consumes more than 1/3 of the territory, aspects falls below 6, that is one of the criteria that puts the patient outside the Class 1 thrombectomy candidacy framework, independent of the timing question. So the cross-disclosure does 2 things at once. It uses the plaintiff's own expert's visuals to argue that the patient was likely already not a Class 1 thrombectomy candidate based on the early CT, regardless of whether the stroke alert was activated and regardless of whether transfer was initiated. And it sets up an internal tension within the plaintiff's case between the radiology expert who is illustrating early infarction and the interventional neuroradiologist who is opining that the patient was a candidate for thrombectomy. The defense is aligning their attack around these issues. The patient was not a thrombectomy candidate based on the initial CT scan as reviewed by the plaintiffs on experts, and the patient could have received TPA earlier if the defendants that had already settled had activated a stroke alert when the patient arrived.
The defense neurovascular research expert, retained by the radiology defendants, was a board-certified physician with academic neurovascular research credentials. His disclosure stated that, quote, "Even if TPA was administered to plaintiff earlier than it was given, there would be no expected change in the outcome. Only potential course of treatment for the patient would have been intra-arterial intervention, a thrombectomy."
That is a specific defense causation claim worth examining. The Get with the Guidelines. Stroke registry analysis published by Fonerau and colleagues in Circulation in 2011. Based on a registry cohort of approximately 25,500 patients treated with alteplase within 3 hours of symptom onset across more than 1,000 hospitals. Reports that every 15-minute reduction in door-to-needle time was associated with a 5% lower adjusted odds of in-hospital mortality. The reported odds ratio is 0.95. The 95% confidence interval is 0.92 to 0.98.
That is an adjusted odds ratio from observational registry data, not an absolute mortality reduction, not a relative risk reduction, not a patient-specific causation formula.
So the defense expert's framing that earlier alteplase would have produced no expected change in outcome runs into observational registry data suggesting that earlier alteplase is associated with lower in-hospital mortality. The literature does not support extrapolating that adjusted odds ratio across long delays to calculate an individual patient's loss chance. But it does support the directional point that timing matters. The defense expert's position can also be read narrowly, that for this specific severe NIHSS, large territory presentation, the marginal benefit of earlier alteplase alone without thrombectomy may have been small. That is a more defensible framing than no expected change. Either way, the dispute is testable on cross-examination.
Peter, 44.
Now the empty chair architecture. After the hospital, the emergency department physician, and the radiology resident settled, the remaining defendants needed to develop expert testimony to support apportionment of fault to those settled defendants on the verdict form at trial.
Here is why that matters legally. An appellate court decision established that, in a medical malpractice case, a defendant seeking to apportion fault to a settled defendant must produce qualified expert testimony to support the settled party's negligence. It is not automatic. The settled defendant remains on the verdict form, but the apportionment is conditional on expert testimony at trial.
That is a critical doctrinal point. In this state's malpractice apportionment framework, the empty chair is not a rhetorical device. It is an evidentiary structure. To get a percentage onto the verdict form for a settled defendant, you have to retain an expert to opine that the settled defendant breached the standard of care.
The remaining defendants did exactly that. The radiology defendants disclosed a board-certified emergency medicine physician. The next day, the on-call neurologist's defense team disclosed a separate board-certified physician with credentials in emergency medicine, internal medicine, and neurocritical care.
The neurology defendant's emergency medicine and internal medicine expert was disclosed to testify that the emergency department physician and one or more members of the hospital's emergency department deviated from the applicable standard of care in the ways outlined in the plaintiff's complaint at Count 1, paragraph 35.
Stop on the structure of that disclosure. The defense expert is incorporating by reference the plaintiff's own pleaded allegations against the settled emergency department physician. He is not developing an independent standard of care analysis. He is adopting the plaintiff's allegations and saying, in effect, yes, those breaches occurred, and the responsibility is the settled defendants, not my retaining parties. The radiology defendant's emergency medicine expert was disclosed in similarly structured form.
The final defense move is the cross-disclosure of the plaintiff's interventional neuroradiologist. Near the end of the discovery period, the on-call neurologist defense team cross-disclosed the same plaintiff's expert who had opined that the patient would have had functional independence with timely treatment.
The defense cross-disclosure used her own causation framework, but inverted. Her plaintiff disclosure had argued that the standard of care required transfer to a regional comprehensive stroke center within 5.5 hours of last known well, and that with timely treatment, the patient would have had functional independence. The defense cross-disclosure adopted her timeline and her transfer benchmark, and argued that the hospital's delay in contacting the on-call neurologist made it impossible for the on-call neurologist to meet her own timeline.
That move closes the empty chair architecture. The plaintiff's own expert has now been cross-disclosed to argue that the missed window was the hospital's responsibility and not the on-call neurologist's. The defense is using her own standard of care framework to push fault onto the verdict form line for the settled hospital defendant.
The defense had 11 experts. 3 to defend the on-call neurologist, 2 to dispute imaging breach, 1 to argue causation against the radiology defendants, 2 empty chair emergency medicine experts, and cross-disclosures of 2 plaintiff experts to use their own opinions against the plaintiff theory.
That is sophisticated litigation. The whole architecture would have been tested in front of a jury. 60 days before that scheduled jury selection, the apportionment notice was filed. The cross-disclosures were filed, the empty chair experts were disclosed, and then on the day before jury selection, both sides settled. The defense had built a compelling case in late discovery to support the notion that any delay or failure to meet the standard of care rested on the settled defendants. They also could have questioned the plaintiff expert further on her statements, suggesting full functional recovery at 90 days, and brought in experts to show that the categorical claim was not supported by the literature, but that was not done here.
The parties reached a final confidential settlement involving the radiology attending, the Radiology Limited Liability Company, the on-call neurologist, and his professional corporation. Jury selection had been scheduled to begin the following day. Evidence was scheduled to begin about 4 weeks later. The amount of the second settlement is confidential.
The case file shows no judicial holding on any of the major contested discovery issues. The court denied the protective order on the picture archiving system audit trail in late 2021. That is the most consequential discovery ruling. The peer review privilege fight, the apportionment notice, the offer of compromise, the cross-disclosures, none of those reached judicial decision before the case settled.
Some cases produce published opinions that shape the law for the next generation. This case did not. What this case produced is a complete map, visible in the docket and the discovery record, of how a complex stroke malpractice litigation reconstructs a hospital's stroke system. Reading that map is what we can do here.
The picture archiving system audit trail. Let's come back to it.
The plaintiff's allegation, based on the audit trail produced by the Radiology Limited Liability Company, was that the on-call neurologist's user account first accessed the early CT images at 9:41 p.m. from a network address with a 192 prefix, which the plaintiff's information technology expert characterized as a home network associated address. The plaintiffs further alleged that at 10:15 p.m., the same time the on-call neurologist had testified in deposition that he was at the hospital, in a physician's room, reviewing the magnetic resonance imaging and CT scan, the audit trail recorded image access from the same 192 prefix. The plaintiffs further alleged that the following day, the on-call neurologist's network identifier changed to a hospital network address, which the plaintiff's information technology expert offered as evidence that the prefix tracked physical location.
Those are the plaintiff's allegations interpreting the metadata. The information technology director of the Radiology Limited Liability Company was deposed twice. The court denied the defense protective order on the audit trail. Those are verified facts. The interpretation of what the metadata means, what a 192 prefix indicates, what the timing sequence implies, is a matter of expert testimony, not court finding.
The deposition contradiction is the case-specific issue.
There is nothing inherently improper about a neurologist reviewing imaging from outside the hospital. On-call neurologists routinely review picture archiving system images remotely, give telephone orders, and then come in to examine the patient. As long as the call schedule and credentialing do not require physical hospital presence, remote image review is a clinically and operationally accepted practice. If the on-call neurologist had reviewed the images from home, given initial orders, and stated openly in deposition, "I reviewed the images from home, gave orders, and arrived at the hospital at X p.m." There would likely be no audit trail dispute. The medico-legal exposure is generated by the contradiction between memory-based testimony and system-recorded metadata, not by the underlying remote review behavior. The teaching point is one we'll return to in Part 6. An audit trail is the chart's flight data recorder. It outlasts memory. When deposition testimony contains an absolute statement that conflicts with system-recorded metadata, the witness's overall credibility can be at risk, even when the underlying conduct was not improper, and even when the witness was not intentionally being deceptive. The discipline is, when you do not know or do not remember, say so. Avoid absolute statements you cannot back up.
The state legal architecture that made this case settle on the eve of trial is worth one more pass.
The state apportionment statute provides that settled and released defendants stay on the verdict form. The percentage of negligence assigned to the settled defendants reduces the remaining defendants' exposure, but only by percentage, not by dollar credit. That is the rule from the state Supreme Court's 2001 decision applied in apportionment practice. The state offer of compromise statute creates conditional 8% annual statutory interest exposure if the radiology defendants reject the offer and the plaintiffs recover at or above the offer at trial. Per the state Supreme Court, settlements do not satisfy the statute's judgment after trial predicate. So the conditional interest exposure hung over the case for 31 months but was never realized. The state's medical peer review privilege statute is narrow. It protects committee proceedings actually engaged in peer review, not every quality-related document. The plaintiff's discovery requests for the Joint Commission certification materials, the Get With the Guidelines registry data, and the internal stroke team logs were objected to under the privilege. The hospital settled before the privilege fight reached judicial ruling. The state's good faith certificate statute requires a similar provider opinion attached to the complaint. The plaintiff's certificate was filed. No challenge to the certificate appears in the case file. The state Supreme Court's 2016 decision recognizing apparent agency in tort, including hospital cases, applies a two-part test involving the hospital's manifestation that the physician was part of the hospital's care system and the patient's reasonable reliance on that representation. In an emergency department context where the patient is unconscious or in extremis, the patient reliance prong is more difficult to prove on a personal reliance theory. The plaintiff theory in such cases is that the patient relied on the hospital as the entity providing emergency stroke care. And finally, the state appellate court's 2003 decision on the lost chance doctrine establishes that the state's lost chance doctrine in medical malpractice requires probability, a categorical greater than 50% threshold, not the mere loss of a sub 50% chance.
That is the legal architecture. Apportionment to settled defendants, offer of compromise interest exposure, peer review privilege, good faith certificate, apparent agency, lost chance. None of these were tested at trial. All of them shaped the settlement.
One more chronological piece worth noting before we move to Part 6. The patient's clinical profile, a previously healthy 50-year-old with a probable patent foramen oval and a paradoxical embolic stroke, fits the demographic that in September 2017 would become the central population for the percutaneous PFO closure trials.
The CLOSE, REDUCE, and RESPECT long-term follow-up trials were published in the New England Journal of Medicine in September 2017. About 17 months after this patient's stroke and 4 years before the case ended in settlement. Those trials supported percutaneous PFO closure plus antiplatelet therapy for selected younger patients with cryptogenic stroke and high-risk PFO anatomy.
That timing is worth noting without overweighting it. The secondary prevention question does not change the analysis of the acute phase decisions on the night in question, but it does deepen the human story. If this stroke had happened 17 months later, the post-discharge management for a patient like this would today likely include consideration for closure. At the time, that conversation did not exist as a published evidence-supported intervention. The 2014 American Heart Association Secondary Prevention Guidance and the 2016 American Academy of Neurology Practice Advisory both supported antiplatelet therapy in patients with cryptogenic stroke and PFO who had no other indication for anticoagulation. The discharge regimen was guideline consistent for what was knowable at the time. We've spent the last hour walking through a single case, the clinical course on the evening in question, the 4.5 years of litigation, the 11 defense experts, the cross-disclosures, the audit trail, the apportionment architecture, the settlement on the eve of jury selection. The goal of this part is not to assign blame for what happened that night. The goal is to read the record the way aviation reads a flight data recorder, to learn from a system that did not function as it was designed to, so that the next time someone walks through the door inside the window, the destination is where they need to be. The framing principle for everything that follows is this. By 2016, this was not an either-or pathway. The 2015 American Heart Association and American Stroke Association focused update was explicit. Patients eligible for intravenous alteplase should receive intravenous alteplase even if endovascular treatments are being considered. Observing after alteplase to see whether the patient improves before pursuing endovascular therapy was not required and was not recommended. The pathway was parallel: alteplase promptly, vascular imaging without delaying alteplase, immediate transfer initiation if the patient could be at a thrombectomy capable center within the 6-hour window. The high-risk miss in 2016 was not simply delayed alteplase, it was delayed recognition that the patient needed a reperfusion-capable destination. A severe stroke syndrome plus possible large vessel occlusion is a destination problem, not only a medication problem. Teaching point 1. The brain attack alert is the upstream pivot. The patient arrived with a Glasgow Coma Scale of 9, found unconscious, gaze deviation. The triage nurses had the information. The emergency department physician diagnosed cerebrovascular accident at 7:56 p.m. None of them activated the BAT alert. The reason that matters is institutional. The BAT alert is not a checkbox. It is the mechanism that distributes the cognitive and operational load of a high acuity, time-sensitive case across the stroke team. Without the alert activated, the entire downstream sequence, neurology consultation, alteplase decision, vascular imaging, transfer call, rests on the emergency department physician alone, who is simultaneously responsible for every other patient in the department. The 31-minute gap from CT signed at 8:59 p.m. to neurology call at 9:30 p.m. is best understood not as a failure of clinical reasoning by an individual physician, but as a downstream consequence of the BAT alert that was not called. With the BAT activated, that 31 minutes would have looked different. Neurology would already be engaged in parallel with imaging review and not waiting on a call from the emergency room physician who could be tied up with other emergency patients. The stroke nurse would already be at the bedside. Pharmacy would already be primed for alteplase preparation. Next shift action. Know your hospital's BAT activation protocol. Know who activates it. You, the charge nurse, a stroke coordinator, know the criteria. If you are the emergency department physician facing a possible stroke, activate first and refine the diagnosis after. Teaching point 2. Parallel pathway thinking. CT and CT, angiogram together when large vessel occlusion is on the differential. The 2015 American Heart Association focused update was specific. If endovascular therapy is being considered, rapid, non-invasive vascular imaging is strongly recommended, but it should not delay alteplase. The CT angiogram acquisition adds minutes, not hours. The information it provides is structural, and it tells you whether thrombectomy candidacy is possible and what destination the patient needs. That recommendation reflects the standard at the time of this patient's care, and stroke imaging guidance continues to evolve. Anyone applying these principles today should anchor to the current AHA/ASA guideline framework. With that anchor in mind, when the differential includes large vessel occlusion, you are managing two questions simultaneously. Question 1, is this patient eligible for alteplase right now, which requires hemorrhage exclusion on the non-contrast CT? Question 2, where does this patient need to go, which requires vascular imaging to establish thrombectomy candidacy and trigger transfer evaluation? Those two questions can be answered in parallel. Next shift action. When the differential includes large vessel occlusion, order CT and CT angiogram together. The protocol your hospital has, and including for transfer pathways, is a sword and a shield only if you actually use it. Teaching point 3, the radiology read. The hyperdense artery sign has high specificity but moderate sensitivity. About 95% specificity for angiographic occlusion when called. About 52% sensitivity in the pooled meta-analysis. It is a sign that is missed often, even by experienced readers. The teaching point is not that any specific radiologist should have called any specific scan. The teaching point is what to do when the radiologist's read does not match the clinical picture. When you see a patient in your emergency room that appears to have a large territory evolving infarct, especially one that presents acutely and the CT scan is read as normal, pick up the phone and call the radiologist. Tell them the stroke symptoms the patient has and ask them to reread the scan. They may pick up the abnormality with more context, and here is the institutional connection. So if this case had been called as a stroke alert from the moment of arrival, the radiologist reading the CT would have had that clinical context already. The BAT alert activation is not just an emergency department workflow tool. It is also a context channel for the radiology read. The CT setting and clinical urgency may have given the radiologist additional reason to look a second time for any subtle changes. The deeper layer in this specific case is that the radiology miss arc and the EVT eligibility arc are not the same case. The radiologists may have missed a callable hyperdense sign, and the parenchymal infarction may have been already extensive enough to weaken class 1 thrombectomy candidacy, regardless of timing. Both can be true. Next shift action for the emergency physician. When the clinical picture suggests a large territory stroke and the CT is read as normal, call the radiologist back. Convey the clinical context. Ask for a reread. For the radiologist, when you receive a stroke alert with clinical context indicating a possible LVO, that is a reason to look more carefully on the non-contrast CT for a dense vessel sign and for early ischemic changes. The phone call in either direction is the discipline. Teaching point 4, deposition discipline and the audit trail. The case-specific issue here was not whether remote image review is improper. Remote image review is clinically routine. On-call neurologists do it every night across the country. The case-specific issue was that deposition testimony placed the on-call neurologist at the hospital reviewing images at a specific time that the audit trail allegedly contradicted. An audit trail is the chart's flight data recorder. It records what the system observed about who logged in, when, and from what network address. It outlasts memory, when deposition testimony contains an absolute statement. I was at the hospital in the physician's room at 10:15 p.m., and the metadata records something different. The contradiction can damage credibility even when the underlying conduct was not improper, and even when the witness was not intentionally being deceptive. The discipline has 3 parts. 1. Do not testify beyond memory. If you do not independently recall whether you were at the hospital or at home, the answer is, I do not independently recall. The audit trail may show where I accessed the study. That is safer than reconstructing from habit. 2. Document remote image review with clinical precision. If you reviewed images remotely, the chart should reflect what you reviewed, your impression, who you communicated with, and what decision followed. The standard inpatient consult note structure, history exam impression plan applies whether you are in the hospital or in your home office. When at home, consider documenting a brief note, including what you were called about, what you reviewed, your impression, and your brief plan, and noting that the image was reviewed remotely. 3. Avoid casual location statements. In an era of remote access medicine, I was at the hospital is a metadata checkable claim. If you are uncertain, frame your answer accordingly. The mistake in a deposition is rarely the underlying conduct. It is the absolute statement under oath that the metadata can later contradict. The teaching is to slow down before you answer. Pause to engage analytical thinking. Ask yourself why the attorney is asking. If you do not know or do not remember, say so. Teaching point 5. Drip and ship as institutional infrastructure. Before we walk this point, an important caveat. The institutional standards we are about to discuss reflect the framework that was in place at the time of this patient's care. Stroke care has continued to evolve. The guidelines today are not identical to the 2016 framework. Anyone in a leadership role should make sure they know what the current standards are and that their hospital's policies reflect those standards. If you are in a leadership role, stroke director, hospital medicine director, chief medical officer, make sure you know what policies need to be in place. Work with your hospital committees and risk management to make sure the policies are based on the current standard of care framing and are protecting the patients as well as the staff. This is an important point for those of us in leadership roles. In this case, the hospital was a Joint Commission certified primary stroke center. It did not have a written drip and ship protocol pre-existing on the date of the event. The on-call neurologist, who was also the stroke director, acknowledged in his cross-disclosure that the protocol had not been instituted. The Brain Attack Coalition's 2013 recommendations for acute stroke-ready hospitals specifically identified drip and ship therapies as a key element. By 2016, drip and ship was a recognized named protocol, not aspirational. This was a potential liability that may not have been recognized before this event. It is a reminder to take a moment and look through your protocols and make sure they are complete. The institutional minimum at the time for a non-thrombectomy-capable hospital that holds itself out as a stroke center included at minimum 5 elements. 1. A working stroke alert protocol that activates fast. 2. Alteplase capability with door-to-needle inside 60 minutes. 3. A working drip and ship agreement with a comprehensive stroke center with prearranged acceptance, transfer destination, and transport rationale documented. 4. Ground and air transport options. 5. A documented door-in, door-out target for transfer-eligible patients. And remember, the drip and ship guidelines are not the same now as they were, so anyone applying these principles today should consult the current guidelines for current best practice. You do not need to be a thrombectomy center to give a stroke patient their best chance. You need the institutional infrastructure to escalate appropriately, and the chart needs to show destination logic. Stroke alert activation, alteplase eligibility decision, vascular imaging plan, comprehensive stroke center contact transfer decision, and the reason for any delay. When the documentation is not there, the litigation reconstructs the gap years later, and not always in the institution's favor. For the audience, if your hospital is a primary stroke center, look up your drip and ship agreement, look up the door and door out targets, look up which comprehensive stroke center you are associated with. If those documents do not exist, that is a quality and safety conversation worth having with your stroke committee long before a case like this happens. Teaching point 6, causation framing under the state's lost chance doctrine. The state's lost chance doctrine in medical malpractice from the 2003 appellate court decision requires probability-based causation. The plaintiff must prove the patient probably would have had the better outcome with proper treatment. The state does not generally allow recovery for the loss of a sub 50% chance. The teaching point is straightforward. Expert testimony must accurately represent the medical literature. When the underlying clinical literature shows the optimal outcome probability is below 50%, your name, as it is for severe NIHSS large vessel occlusion thrombectomy outcomes per Hermes, an expert who claims a patient would have had functional independence is making a claim more definitive than the data support. That is a credibility issue and a Daubert or comparable expert admissibility issue. It is not a structural feature of the legal system. The plaintiff's counsel carries the burden of meeting the state's causation threshold. That is their job. They can argue patient-specific factors that move the probability above 50% for the specific patient, collateral imaging, age, baseline function, infarct size, occlusion location. They can argue alternative legal theories, but the expert's job is accuracy. If the literature does not support a categorical claim, the expert should not make one. The audience can evaluate in any specific case whether the testimony stayed within what the data supports. For the physician audience, this is an important framing for those of us who may serve as fact witnesses or expert witnesses in litigation. When you are asked to opine on causation, the discipline is the same as it is at the bedside. Stay within the literature. Identify what the data show and what they do not show. If patient-specific factors change the probability for this patient, identify those factors. Do not let the question framing pull you into a categorical claim the underlying evidence does not support. Closing reflection. Reading this case as physicians, here is what stands out. This patient was clearly having a large territory infarct. According to the plaintiff's own radiology experts' demonstrative diagrams, the early CT already showed early infarction and edema consuming more than 1/3 of the middle cerebral artery territory. If that is accurate, the patient may not have been a Class 1 thrombectomy candidate from the moment the CT was acquired because of the existing infarct burden, independent of the timing question. The radiologist also missed the dense MCA sign that the plaintiff's experts identify as visible on the early CT. The patient did receive alteplase, 3 minutes inside the 4.5-hour window. We can argue alteplase should have been administered earlier for a better outcome potential, but this patient presented with a very serious stroke. Even with timely, efficient care, the chance of full functional independence at 90 days was modest. That brings us back to the plaintiff expert's earlier claim that with timely treatment, this patient would have had functional independence at 90 days. Per the Hermes meta-analysis available at the time of this case, the chance of functional independence even with optimal thrombectomy in this severity range was about 23%. The expert's categorical claim was more definitive than the underlying literature supported. That is worth remembering when we hear similar testimony in other cases. That is a sad case for the patient and his family. It is also a case where the failures on the medical side, not calling the stroke alert, the delayed CT angiogram, the delayed neurology consultation, the delayed alteplase, the missing transfer protocol, are where our learning points should focus. Our role at the Charted Defense is not to dwell on questions that did not get decided by a jury. Our role is to learn from these cases so we can apply changes in our own practice and in our own institutions to reduce the likelihood that the events alleged here happen again to a patient in our care. The practical takeaway: make sure you have processes in place to identify patients who might benefit from a thrombectomy-capable center. Make sure you have efficient ways to get those patients where they need to be. Do not delay for unnecessary imaging or procedures. The protocol on paper is only as good as the system that activates it.
Until next time, document well Ask the question early. And remember that a severe stroke syndrome plus possible large vessel occlusion is a destination problem, not just a medication problem.
Thank you for listening to On the Record, the long-form deep dive series of the Charted Defense. The companion newsletter for this episode goes deeper into the documentation framework, the legal architecture, and the next shift action items. You can find it at the link in the episode notes.
The Charted Defense is educational only. Nothing in this episode is medical advice or legal advice. Standard of care varies by jurisdiction and by case-specific facts. Until next time.
This podcast is for educational and informational purposes only. It is not medical advice, legal advice, or professional advice of any kind. And it does not create an attorney-client, physician-patient, or other professional relationship. Any discussion of cases, outcomes, standards of care, statutes, or regulations is general in nature, may be incomplete, and may vary by jurisdiction and over time. Listeners should consult their own attorney, malpractice carrier, risk manager, or qualified clinician for advice on any specific matter. Any case discussions are based on public records, de-identified information, or educational reconstruction. The views expressed are those of the speakers and do not necessarily reflect the views of any employer, hospital, health system, insurer, or affiliated organization.